Hi everyone, welcome to our module on thyroid cancer. Before we talk about specific types of thyroid cancer, let me review a few general principles of thyroid malignancies. The first thing you should know is that thyroid cancer usually does not present with hyper or hypothyroid symptoms. It usually presents as a painless nodule in the thyroid. Sometimes patients notice these themselves, but more often they're detected by a physician on a routine examination. And the vast majority of thyroid nodules, as we will see, are benign adenomas, but the concern anytime you detect a nodule is, could this represent cancer? There are a number of ways to sort out whether a nodule is an adenoma or cancer, but one of the definitive ways is to do a special test for thyroid diagnoses, and that's called a fine needle aspiration. So the thyroid is a very vascular organ, so it's difficult and risky to biopsy it. So often what is done to evaluate nodules is to stick a needle in and take a sliver of tissue out of the nodule, and then you can look at it under the microscope to try and determine whether or not it is cancerous. But of course, a fine needle aspiration is invasive, so there are a number of non-invasive tests of the thyroid that are often used to work up adenomas. One of the ones you will most commonly see used is a thyroid ultrasound. There are certain characteristics of nodules by ultrasound that can suggest cancer. You can look at the borders of a nodule, the vascularity, or the presence or absence of calcification, and all of these things can help you determine whether a nodule may be cancerous. In addition, you can use thyroid ultrasound to measure the size of a nodule and follow it over time to see whether it's growing or whether it is stable. Another non-invasive test to work up thyroid disorders and thyroid nodules is a test called radioactive iodine uptake. In this test, patients are given a small oral dose of iodine-131, which is radioactive. That iodine will concentrate in the thyroid gland, and then you can use a machine called a scintillation camera to take an image of the thyroid, and it will detect the radiation being emitted by the iodine-131. And a normal thyroid will show diffuse even uptake of both lobes. This is a picture of a radioactive iodine uptake test of someone with a normal thyroid. You can see two lobes that are both lighting up equally and normally. If you see diffuse high uptake of the iodine-131, that means that the thyroid gland is overactive. That's what you can see in disorders like Graves' disease, where the patient is hyperthyroid from excessive production of thyroid hormone. If you see diffuse low uptake of the iodine-131, that's what you can see in patients with long-standing Hashimoto's thyroiditis, where the thyroid gland has begun to be burned out. If you see multiple focal areas of high uptake, this can suggest nodular goiter. It means that the patient's thyroid gland has lots of little focal areas producing lots of thyroid hormone and therefore taking up lots of the iodine-131. Now in patients who have a nodule, the nodule can either be hot, meaning it takes up lots of the iodine-131, or it can be cold, meaning it does not take up any of the iodine-131. A single hot nodule is what you often see in patients who have benign adenomas. These adenomas often take up the iodine and synthesize thyroid hormone. If you see a single cold nodule, this suggests that the patient may have a cancer. Most cancers do not make hormone, and about 10% of cold nodules are malignant, so you can imagine that if someone presents with a thyroid nodule, you could do a radioactive iodine uptake test, and if you found that the nodule was cold, you then might want to go and biopsy it because there's a chance it could be malignant. Now I'm going to begin talking about specific thyroid disorders, and before I get into the malignancies, let me talk about a very common cause of a thyroid nodule that is benign, and that's called a follicular adenoma. This is a common cause of thyroid nodules. It is a benign proliferation of the normal thyroid follicles, and if you do a biopsy, you will see normal follicular tissue that is completely surrounded by a fibrous capsule, and the words completely surrounded are very important. If the follicular growth breaks through the fibrous capsule, then you have a follicular carcinoma, which we'll talk about later. But in a follicular adenoma, the growth is completely contained by the fibrous capsule. This has important implications for workup of nodules. Because a follicular adenoma must be completely contained in order to be benign, this means a fine needle aspiration biopsy cannot distinguish between adenomas and cancer. That's because a fine needle aspiration biopsy cannot see the entire capsule, and follicular carcinoma has similar histology to follicular adenomas by FNA. To understand this, let's imagine that we have two thyroid nodules. In one nodule, there is a completely continuous fibrous capsule with some adenoma tissue inside. In the other nodule, the adenoma tissue inside has broken through the capsule and begun to spread. This is a cancer. If you do a biopsy of this one on the left, you will see a slice of tissue that has some capsule and some adenoma tissue. If you do a biopsy of the nodule on the right, you will also see some capsule and some adenoma tissue. The fine needle biopsy, because it is a very thin slice, cannot tell whether all of the adenomatous tissue is contained by the capsule or not. Therefore, when you do a biopsy and you find follicular adenoma tissue, you have to take special precautions to make sure it's not a malignancy. In actual practice, when a fine needle aspiration shows follicular pathology, it's often followed over time, and if the adenoma begins to grow or develops suspicious findings like irregular borders, then often the patient goes to surgery because you need to remove the entire thyroid to determine whether or not you have an adenoma completely contained by a fibrous capsule or whether you have a carcinoma. Okay, now we'll begin talking about the 4 types of thyroid cancer, and these 4 types are papillary, follicular, medullary, and anaplastic. Far and away the most common is papillary. Over my career, most of the patients I've seen who had a cancerous thyroid nodule turned out to have papillary carcinoma. So papillary carcinoma is the most common form of thyroid cancer. About 80% of thyroid cancers are papillary. A very important risk factor for this type of thyroid cancer is prior radiation exposure. So some children have radiation to the chest or the mediastinum for malignancies. Some teenagers with severe acne sometimes have their face radiated. And in any of these cases, there's exposure to radiation that raises the risk of papillary carcinoma. There's also a lot of this type of cancer seen in Japan among people who survived the atomic bomb detonation in the 1940s. There's also a lot of papillary carcinoma among patients who live near Chernobyl in Russia, where there was a nuclear power plant accident several decades ago. This cancer often presents as a painless thyroid nodule. It's often picked up by a physician or sometimes the patient, and sometimes it's even picked up by chest or neck imaging. For example, if the patient has a CAT scan or an MRI of the chest, sometimes the neck can be visualized and a thyroid nodule will be noticed. The diagnosis is often made after a fine needle aspiration is performed and the characteristic histology is shown, which I'll show you in a minute. This cancer has an excellent prognosis. It's treated with surgery to remove the thyroid gland plus radioactive iodine ablation to ablate any residual thyroid tissue. So the reason it's called papillary is because on biopsy you see papillae, which are finger-like projections of cancer tissue. That's what's shown in this portion of the slide here. Oftentimes these purple structures form little finger-like projections, and that's how it gets the name papillary carcinoma. There are 3 classic pathology findings of papillary thyroid cancer that you need to know, especially for step 1. The first is the presence of psammoma bodies. I'll show you a picture of these in a minute. The other 2 findings have to do with the nuclei of the cancer cells, and these are the presence of nuclear grooves or orphan Annie's eye nuclei, and it is the presence of either of these nuclear findings which make the diagnosis of papillary carcinoma. Pathologists will look for these, and when they see the characteristic nuclear findings, they can call the cancer a papillary carcinoma. Psammoma bodies are calcifications with a layered pattern. This is a picture of one shown on the screen here. You can see psammoma bodies in other neoplasms, but among thyroid cancers, you only see psammoma bodies in papillary thyroid cancer, so that's why their presence is useful to make the diagnosis. Nuclear grooves are dark lines in the nuclei of the cancer cells. You can see a good example of one right here. I'm circling it on the screen. You can see a dark line across this nucleus. That's called a nuclear groove, and their presence is diagnostic for papillary thyroid cancer. Little Orphan Annie was a cartoon in the United States in the early 1900s, and in the cartoon her eyes were always drawn as these white circles, as I've shown on the screen here. So for this reason, the nuclei seen in papillary thyroid cancer were named Orphan Annie's eye nuclei, and that's because they have white clearing in the middle. There's an example of one shown at the bottom left side of the screen here. You can see that this nuclei has the purple material being pushed to the sides, and there's white clearing in the middle, and that reminded pathologists of the Orphan Annie cartoon, hence the name Orphan Annie eye nuclei. The second most common type of thyroid cancer is called follicular carcinoma, and I mentioned this before, but this has pathology that is very similar to a follicular adenoma. However, the tissue breaks through or invades the fibrous capsule, and that's what is the difference between follicular carcinoma and a follicular adenoma. And as I talked about before, this means that a fine needle aspiration biopsy cannot distinguish between a benign adenoma and a cancer. So as I told you a few slides ago, if you do an FNA biopsy and you see the presence of follicles, like I've shown on the screen here, what you have to do in that case is follow the patient closely over time. If the nodule gets large and grows, or if it has suspicious findings like irregular borders, the patient is often referred to surgery out of concern that they may have developed a follicular carcinoma. Most carcinomas, you may know, spread by the lymph nodes. However, follicular carcinoma is an exception. It can spread through the blood, which makes it unusual. The treatment is usually to remove the thyroid gland and then administer a high dose of iodine-131, which will ablate any remaining tissue or metastasis. This is a radioactive version of iodine, the same version we talked about before, that can be used at a small dose for diagnosis. If you give a large dose, it will be taken up by thyroid cells and it will destroy the cells when it emits radiation. Medullary carcinoma is the third most common type of thyroid cancer. It's very rare. It's a cancer of the parafollicular or C cells of the thyroid. Recall that these are the cells that produce calcitonin. Calcitonin is a molecule that lowers serum calcium, and normally it has a very minimal effect on maintenance of calcium levels. It's not very important in humans. However, if a patient develops a medullary carcinoma and has a malignancy, there can be so much calcitonin produced that the patient can develop hypocalcemia. And one of the most high-yield things to know about this cancer is that it can present as hypocalcemia. Another high-yield thing to know about medullary carcinoma is that you will see amyloid in the thyroid on biopsy. Recall that amyloid is deposition of proteins, and calcitonin is a peptide, so it is a protein, and when it builds up in the thyroid, it can appear like amyloid tissue on biopsy. So here's a picture of what medullary carcinoma might look like on biopsy. These are all cancer cells in here. The red stuff is amyloid. It's often described as malignant cells surrounded by amyloid stroma. MEN syndromes are multiple endocrine neoplasia syndromes, and we'll talk about these in more detail in a separate module, but for our purposes here, I just want to remind you that they are gene mutations that run in families that cause multiple endocrine tumors, and there are two MEN syndromes that are associated with medullary carcinoma. MEN2A and 2B are both associated with medullary thyroid cancer. These two MEN syndromes are caused by RET oncogene mutations, and some patients who have the RET oncogene mutation of one of these MEN syndromes undergo elective thyroidectomy. Even though they don't have cancer yet, they will electively have their thyroid removed so that they aren't at risk of development of cancer. They can then take thyroid supplementation for the rest of their lives to maintain a euthyroid status. The last type of thyroid cancer is called anaplastic carcinoma. It's also sometimes called undifferentiated carcinoma. This occurs in elderly patients. It is a highly malignant cancer. It often invades local tissue, and the way they are likely to ask you about this rare tumor on step one is to use it to test your knowledge of anatomy. So you need to know the structures that are near the thyroid gland in order to understand what can happen when this tumor grows locally. So it can grow into the esophagus and cause dysphagia. It can grow into the recurrent laryngeal nerve and cause hoarseness. It can grow into the trachea and cause dyspnea. And in the module on thyroid disorders, I talk about a condition called Rydell's thyroiditis. Rydell's thyroiditis can also cause these things. However, Rydell's thyroiditis presents as a rock-hard thyroid, and it occurs in younger patients. When you see these types of symptoms in an elderly patient, you should think that they probably have anaplastic carcinoma, because the elderly are an unusual demographic for Rydell's thyroiditis. Anaplastic carcinoma carries a poor prognosis, and on pathology you will see undifferentiated cells. Basically, there are cells that will not form papillae like papillary carcinoma. They won't form follicles like follicular carcinoma, and you won't see any amyloid or other features to suggest medullary carcinoma. And that concludes our module on thyroid cancer.